Hi there, everyone.
Hello.
That was quick, Bruce. Agreed. But we made it back. This whole time has gone so quickly. I can't believe that we are more than halfway through our summit. And I'm so grateful for everyone that showed up and hung out with us in our breakout sessions and really opened your minds as to thinking about this path towards equity. I loved getting to engage with the folks in my group and hearing the feedback and just kind of seeing the synergies that lived across everything that we're doing. We're going to shift gears a little bit, but stay in the same theme and in the same lane and talk to a set of folks who really have some incredible insights, some incredible experiences, I think can land us in the space of how we think about and how we move along this path of health equity, whether deploying technology or new and innovative ways of doing things. So I'd love to introduce Tracy, KP, and Anoop. Tracy Dooley, Dr. Tracy Dooley, she's a biomedical engineer who turned physician, who pivoted to support innovation in the healthcare space, really working first with firms such as Novartis, where she really thinks about operations and built out the innovation pipeline, as well as kind of working with early stage startups. Tracy, can you say hello and tell us a little bit about your work at Avestria these days?
Yeah, hi everyone. And thank you so much, Monique and the whole team for inviting me. I mean, I'm just really thrilled to be in conversation with all the folks today. And it's been just already so energizing. And this is one of my favorite things to talk about. And luckily I get to do this for work too. So as Monique mentioned, at Avestria, we invest in female founders in life sciences and the health of women. And since women are not small men and we don't limit ourselves to reproductive health, right? So that being said, we're looking at things as broadly as cardiovascular disease and neurodegenerative disease and autoimmune disease, obviously then also to things like maternal mortality and menopause and things like that. But I think that we also really make sure that we take a very intersectional view of that. And so it's not just women that's tagline, but it's kind of everybody who doesn't fall into that very standard 70 kilogram white male, and how can we drive insights that make things better for everyone. So that's us.
Awesome. Tracy, phenomenal to have you. Just a quick reminder as well, if you're trying to find our panelists and who's speaking, you can flip to speaker view and you'll be able to see us. Next, we have Kaakpema Yelpaala, who goes by KP. KP, great to have you. You've been an incredible partner to Health DesignED as we've, in our efforts to bridge the digital divide in healthcare. And you really share our passion and our vision and values around what's global and a cross-market perspective. You started your career at the Clinton Health Access Initiative, as well as Dahlberg, before launching access.mobile and InOn Health in the US. And your team is certainly leading around deploying omnichannel approaches to improve access, equity, and outcomes. I know you sit on the advisory board for Yale School of Public Health, as well as are a thought leader in your own right. Can you tell us a little bit more about your work in Colorado around equitable tech-enabled care and nationally in the fight against COVID?
Great, thanks, Monique. Really appreciate you and bringing together this forum. I feel like you've got our creative juices going. So I need to try to stay in my 1 to 2 minutes. I really like the process you just put us through. A bit about what we've been doing in Colorado and nationally. We've been focused from very early on issues around equity and COVID. That started early in the pandemic, so last year around testing. So we were working early on with COVID Check Colorado, which was the largest provider of community-based testing and school-based testing in the state of Colorado. And so we kind of started on that journey. And then as CARES Act money came in last year, we were a part of that big push to just get as many people tested as possible in an equitable manner. And then fast forward, when I had the chance to meet Monique, we really were able to think about the model we were designing in a more structured manner. And we called it the connected community of care model, which really at its heart was understanding that you needed trusted organizations and trusted channels to have any chance at moving the needle around COVAX testing and vaccination access. And so then we implemented that with you guys in Atlanta. And now we're moving towards a new domain around using data to help support action at the community level. And when it comes to our current inequities with regards to vaccine access here in the US, we know that part of the problem we have is not every state or local jurisdiction is making vax data available down at the census tract level by race and ethnicity. New York City has been a place that's done that well. You could go to their site now. There's a GitHub repo. You can grab that data for every census tract in New York City. Because we have not had that data in places like Colorado, we designed an index that basically calibrates vax rates from the county level down to census tract with other indicators, such as the COVID Community Vulnerability Index from Sergo, and basically allows, COVID Check, and now over in Atlanta, our friends that we're working with there, to figure out where to have the biggest bang for buck from a health equity lens down to the census tract. Because really at the heart of the matter now, as we try to get more vulnerable populations the vaccine, is we have limited resources and we don't know where to go. I'll give you a short anecdote. So COVID Check Colorado has been doing door-to-door work here in Colorado to find people to get the vaccine. And we were using this data and index to go into communities and knock on doors. And early on, we had really good yield because at that time, not as many people had been vaccinated. So our ability to knock on a door and find someone that had an access barrier and get them a shot was pretty effective. Last week, we were talking, and very recently, COVID Check knocked on 1,000 doors. This was primarily in Denver Metro and low-income census tracts. About half the doors they knocked on, people had been vaccinated, which was good. But they only picked up 4 people to get vaccinated out of 1,000 doors they knocked. Why? Because no one's sharing the data. So this now is the issue of efficiency. Our ability to be efficient in how we solve the equity issue really requires that our stakeholders locally and nationally share the data and be transparent about what's going on. So I've been really pleased and blessed to meet Monique and to partner on these type of issues. That's just a snapshot of what we're working on.
KP, always great to partner with you guys. Love how you guys are leading on data and love how you guys are really helping us think through the behavioral insights of how we impact communities. And Bruce, thanks for sharing that in the chat. Let's remember to keep the chat popping. We also have with us Dr. Anoop Raman. Anoop, you're a family doc, committed to serving the underserved, certainly. And you've really been an incredible actor from working in the chronic care and community health center space, whether you're working at the Partners in Health in Rwanda, to really bringing your deep population health expertise to the U.S. to centers that are across the nation. Can you tell us a little bit more about your role as a chief medical officer at AbsoluteCARE and the work you're doing to remove barriers to equitable healthcare?
Thanks so much, Monique. And again, just would echo KP. This was an incredibly fun exercise and incredible just to be with all these very cool, very passionate people. So thank you. Yeah. So what AbsoluteCARE does. So we are a concierge PCP-led organization that takes care of the sickest 3% of people on public insurance, Medicaid and Medicare. Another sort of term for us is ambulatory ICU. So basically the highest outpatient care that you can deliver to the folks who need it most, right? And so it's really about, if you believe that healthcare is a right, it's really about matching need with intensity of care, right? Our other tagline is we're concierge care for the sickest instead of the richest. The way that our model works at a high level, there's sort of 3 components, right? Identify, engage, transform. So identify, so who are the sickest 3%? Our organization's focused on, we partner with payers, exchange data, and we look at people who year over year are increasing their use in utilization and chronically are in that highest 3%. And so it's not like a one-time event that made them high cost and then they came back down. It's year over year. When you think sort of broad strokes, what that archetype looks like of who ends up being in that category, it ends up being like 4 archetypes. So one is medically complex, right? So not just diabetes, but A1C of 15, status post 2 amputations, has end-stage renal disease and congestive heart failure, right? That's not uncommon presentation for us to treat outpatient. Second category is folks who struggle with serious persistent mental illness. So folks who have schizoaffective disorder or bipolar disorder and end up using the health system and ending up in the ER, as you know. And third category is folks with substance use disorder, particularly opioid use disorder. And then fourth, life issues. The jargon du jour is social determinants of health, but people who struggle with food insecurity, transportation barriers, and housing instability. That's who we serve. And it's not like our patients fall into one of those categories. Sometimes it's two, sometimes it's all four, right? And then, engage, we go and we knock on doors, make phone calls, and talk to people about their insurance company making them eligible for these services. About a third of the time, folks will choose to have us be their PCP. And then the fun starts, right? The transformation piece. So how do you actually change the trajectory of someone's health and life? And so the way that, we haven't solved everything, so we're consistently learning. But the way that our model works at a high level is, first we knock down the transportation barriers. So we transport all of our members to the center for their appointments, either in our own vans or by Uber. Very small patient panels, less than 350 per provider, opposed to the typical 2,000 per PCP. Instead of just doc and MA, it's doc, MA, plus 2 nurse care managers, plus a social worker. We also, for every 2 teams, have a behavioral health worker and an outreach worker. So you're talking about 12 to 14 professionals focusing on 700 high-cost individuals. And then we're trying to be a one-stop shop. So we have an integrated pharmacy on site, so we can ensure that when we write for medicine, people actually can take it and can afford it. So we'll waive copays for that. And the model works. So, ER use and hospitalizations go down by about 40%, total cost of care by 20%. And it ends up being, a win for the patient because they're healthier and at home instead of in the hospital. Win for the provider because you're practicing at the top of your license and really using your full skill set. Win for the payer, they're paying less per member per month. And then win for society, again, because when you think about who deserves and needs this highest intensity care, it's the folks who are the sickest, right? And so, right now we're in Philly where I practice, Baltimore, Atlanta, and we're opening up a new center in New Orleans. And, our goal is basically to have an AICU in every city in America. So we're in active talks in Chicago, Detroit, and New York next. If we're not near you, we hope to be soon.
Well, we're certainly happy that you're bringing that model to Atlanta, without a doubt. Me and my emergency colleagues, thank you for joining us. One of the things that really resonated was this idea of how do we design for the people with highest need, right? And oftentimes that's interlaced with all the elements of equity that we think about, and inequity that exists within our social structures, our culture, our economies, everything that brings to bear. And Anoop, I'm curious, when it comes to health equity and healthcare, what keeps you up at night? What are the biggest questions that you're thinking about?
Yeah, so I think what I think we've learned most as an organization is this was founded by doctors, and so we think from that medical model, right? And what we've quickly learned is, I just laid out four archetypes or categories of our members' needs, right? Only one of them is medically complex, right? So how are we integrating behavioral health and psychiatry meaningfully, right? How do you engage with someone who has a BH disorder but doesn't want to talk to a behavioral health therapist, right? So figuring out how to meet people where they're at with that. And then one thing that we're really stepping with both feet into is how to address social determinants of health meaningfully, right? So when we know someone's going to the emergency room, now we are, because of housing instability, we will rent them a home for here on out. So like a targeted housing first approach. But we know that there's so much to do there, right? And like, how can we be more programmatic about that? So one thing is not using just sort of that like physician medical lens when you're looking at a population. And the next is also not making assumptions. So one thing that we're talking about in our breakout rooms that Sophie mentioned that really resonated was the idea that you need multiple entry points to our health system. And so, initially we had just said, okay, our population is very poor, very vulnerable. Like we don't need for example, we don't need a patient portal, right? Because they're not going to use it. That was an assumption, but turns out not right. So, there is a good chunk of our population that would make phone calls or need to walk in for care, but there's other folks who would be, there are other folks who would benefit, right? And so needing to design for that diversity within your population is really important. I'm curious, actually, KP, what are you thinking about nowadays?
Yeah, you've laid out a lot of good ideas there. I mean, the thing that's keeping me up at night, particularly these days, is digital divide. And I won't lie, it's because, I don't really see how we don't end up in a situation where our vulnerable populations are worse off very soon. And the reason is this: we've had the biggest quarter of venture spending in digital health this past quarter. So Q1 of 2021, more money was invested in digital health than all of last year. And when I look at digital divide, my concern is that when it comes to venture, and full disclosure, we're a venture-backed business. When it comes to venture, if venture is following the money and looking for the big opportunities with the best returns, it's not the digital divide. Yet I also don't see the foundations that are really supposed to fill the gap thinking much about digital divide yet, or figuring out how to deploy money into that space. And we're already seeing this in COVID. We saw this when we looked at telehealth adoption curves last year, right? Because telehealth adoption, because of COVID, skyrocketed, but it didn't skyrocket for everybody, right? And this pattern is continuing.
Such a great point, KP. When we think about the, hundreds of billions of dollars that we're really spending on just this idea of health disparities and the fact that all of this unaddressed need exists out there, there's an opportunity that the money isn't falling and that we're not turning our eyes towards because we're not thinking about what it means to keep societies and communities well and how we think about equity and well-being. Tracy, I'm curious.
Great. Can you guys get me back? I think I dropped.
I think we hear you. You're back on.
Did you get me back? Sorry, I'm competing for internet with my kids now, apparently.
We all are. This is the digital divide in action. KP, well, we can hear you.
In action.
With a little bit of a lag.
Apologies. Yeah, I think you might have picked up. Yeah, I'm sorry. I'm going to switch to my phone, but just digital divide has me concerned. I think you guys got the sentiment. So how do we ensure everyone's included? Yeah.
While you switch over to your phone, Tracy, I'm curious, what are you seeing from your vantage point? Where are you seeing equitable tech-enabled care solutions coming down the pike?
Yeah. So, I would echo, what Anoop and KP are saying, everything about that. Completely agree 100%, right? I think one, starting from the perspective of what's your real unmet need, right? And then from a very clinical perspective, but then also thinking about it, not just from a clinical solution perspective, but from a holistic, again, we're going to use the SDOH sort of buzzword, but you really got to think about the patient and what they have as sort of access, right? And bring that into the solution when you're thinking about what might be able to really make an impact. And of course, the digital divide is incredibly powerful in terms of really thinking about how you're going to be able to lift the tide for everyone, and not just for what we don't invest in is we don't invest in healthcare for the 1%, right? We want to tackle the biggest problems. And oftentimes, so for venture specifically, right, I think that's one of the things, right? Because the object of a venture fund is to make money for their limited partners, right? And so being new to venture, right, and having done this from a strategic perspective, from a corporate perspective, I think there's so many ways to think about partnerships and funding and sources of capital and sources of liquidity for early stage companies, right? And so venture tends to be the one that's marketed very well, that's hyped, right? That has shows like Silicon Valley about it, right? But it is one of the most expensive and oftentimes not the most appropriate source of capital, right? So I think one that, now that we're seeing funding come out, from the NIH and with SBIR grants and early stage grants, I think those sources of capital are really important. And so I think somebody in the chat asked about if government is part of the answer. And I would say, yes, absolutely. We all need to be part of that answer, right? So VC is sort of a very small portion of that. So what I do see exciting about this is because when you put tech together with healthcare to solve some of these problems, it seems like we've really sort of gotten to a tipping point where it can really accelerate and scale very rapidly. And I think that's what I've been seeing a lot of. As KP pointed out, the last year has been enormous for digital health. That being said, almost half of those investors, 300 out of the 700, are new investors to digital health, right? So you've also got folks who have not necessarily been playing in the space before or who have been familiar with that. And so I think one of the things that we really want to look at, particularly at Avestria, is, we diligence everything like we were at our strategic, but we really look at adoption. We think very carefully about do the founders and do the folks who are creating the solution have that lived experience, and can they bring that there? Because I think we don't want to come in with somebody saying, I'm going to solve this problem for someone else. We want them to really critically understand that problem. And then I think there's all the other things that we have to look at, but it really stems from, do you have a really clear understanding of that problem? And then are you building that solution? And then not only just from your own experience, but bringing in other folks who are going to address that as well. So, but, I think one of the interesting things I've seen is that, one of the folks I was talking to about underhoused population says that they sell access to their phone in order to get money, right? So that's a great example of the digital divide, right? Where you can't rely on one person, one device, or even consistent access to that, right? But Monique, I would love to hear about what you've been seeing in terms of what you think folks can be doing to be more equitable.
Well, Tracy, I think you bring up a really good point of who are we designing and for what? I think sitting within a large healthcare system, often, we see folks come to our doors with really great and interesting solutions that just have never thought about equity, right? It's never been planted in the conversation. They've never been asked about it. And so when you think about the usability of the solutions, if you think about the type of traction that they're able to gain, it's not usually across an equitable, it's not across a diverse population, right? And so I think one of those elements is, well, what we've been doing today is when you're starting that design process, being very intentional about embedding equity within, throughout, iterating back to understanding who are you designing for, and making sure that you're continuing to follow that vision. And I think, both you and KP make phenomenal points in that there is not only great need, but there's also great opportunity in designing for, populations in a more equitable way. And that one, the need is there, it's real, there's true market opportunity, but as well, there's the element of when it's not out there, it's something that people want, right? It's something that adds value in multiple different layers in different ways. And I think as a healthcare system, it's great to be able to weave these elements together. I think one of the things that we enjoy is not being siloed, but being able to pull these solutions together, not just as one for specific population, but across a diverse population, and co-developing and collaborating with groups, and also thinking in a broader scope of 4 different communities, 4 different members from different parts of our ecosystem. How can we all move on this journey together to making sure that people have access and people have, a way to navigate the healthcare system, as well as the opportunity to support their well-being in a meaningful way.
Monique, can I add something that I just missed when my line went? It came clear in the process you had us in before, which is for safety net or for vulnerable populations, the digital divide issue in terms of getting things to work better is both a provider side and a patient side issue. So I think a lot of times we're thinking about design for vulnerable populations, meeting them where they are through mobile phones or whatever it may be. But then sometimes we may need to remember that the providers themselves also need their bit of digital transformation. And so I think what you're framing is, I don't hear as many people talk about both the provider and patient side of this design process. I mean, that came out in our kind of creative process earlier, but I wanted to share that.
I'll add one more thing in there as well. Often when we think of vulnerable populations, we automatically seem poor, low income, think about Medicaid primarily. But when you look at the health equity numbers, when you account for income, when you account for, whether people are insured or not, you simply see that particularly Black and Brown people just don't do as well. I mean, to be a Black woman in this country and to give birth is really a serious thing. And it doesn't matter how much money or education you bring to the bank with you, you're still at very high risk. So as well, making sure that when we're designing across diverse populations, that we're thinking through all of those elements to bring to bear, to make sure that we're really addressing at its core that issue of the well-being at the other side and the outcomes at the other side, because our populations are diverse and rich in very different ways. I'm curious from all of you about what you're excited about in health equity moving forward. It's certainly been a year in which we've been challenged by COVID, where health equity has been front and center, and a lot kind of weighs on us from that perspective. But what gets you excited these days? And maybe this time we can start with Tracy.
Oh, well, so I was just replying in the chat actually to the earlier question around what are we excited about? And so full disclosure, these are a couple of our recent portfolio companies, but I just want to talk about them as examples of what we love, I think in addition to the fantastic examples of what Anoop and KP are both doing too. So DrugView is building a real world evidence platform in autoimmune disease with so autoimmune disease is probably 85% woman, right? But more than that, they're also focusing on communities of color, because even though, in clinical trials, non-white people are about 10% of clinical trials, obviously the representation in the general population is 40%. And that sort of divide is really unacceptable. And that moves all the way down the line, because, when you're thinking about products that have been FDA approved, when you're taking a therapeutic, you expect that it's going to work, right? But I think that we're really at the cusp of being able to utilize a lot of the data, a lot of the insights that we have to really drive much better outcomes and much better solutions and treatments for folks across all walks of life, right? And I think that promise of personalized healthcare and being able to meet people where they are and being able to say, we think this is going to be the best for you based on the research that we did in this group of people who is also very similar to you, is so impactful, right? So I think that's really incredible. And, I think on the other side to Meet May is connecting Black expectant moms to doulas to provide culturally competent care and to address the maternal mortality crisis. And the CEO there, Maya Hartigan, is laser focused on the Medicaid payer space, right? So thinking about who the stakeholders are in the ecosystem. Yes, the patient, yeah, absolutely, or the mom is the ultimate customer. But when you're thinking about who do you get to pay for it and how do you think about what the metrics are and what is what is the impact that they're going to have? Absolutely, payers are going, and Medicaid are going to be an enormous component of that piece in the ecosystem as well. And so she's designing very intelligently for both of those things, And so I think that we're really seeing that folks can bring all these things together, which is really exciting. So those are just a couple of things. What about KP and Anoop? You two, what have you been seeing?
Anoop, you want to go for it first?
Sure. This question came up about funding and what can government do. I think what, most of my life I've been working in the nonprofit sector. And so I was always curious, like, can private equity really lead to health equity, right? And was fairly skeptical, but, I'm watching, very well-known organizations in the value-based care, primary care space that I work in, like Oak Street Health or ChenMed or Iora, you can see this actually in action, right? Where literally some of the best care with very talented physicians, very talented operators, are providing just very high level service to the poorest communities in America. I'm watching it right here in Philadelphia, billboards, and like you walk into these centers and they're beautiful, right? and it's real, the impact and the outcomes, right? And so now, as someone who's on the inside of one of these organizations, I can just attest to the fact that that there is, our health system is so broken that there's so much room for private equity to do good in this space, because we're in this unique moment where health equity is actually addressing it meaningfully, is actually profitable, right? And so, and that's actually part of how fixing the health system, is when you're aligning incentives so that when you do well by the people who need it the most, and you're actually be able to be financially sustainable, that's success, right? So to me, that's incredibly exciting, where I feel like when I'm working, I'm not needing to make ethical compromises in order to make money in healthcare, which is not always the case if you read about healthcare generally.
Ditto on that. I think it's incredible to see health equity into focus, and the way that the pandemic has created that space for people to understand how that incentive can be aligned, and that profit and progress and impact don't have to be perpendicular to each other, but they can move along and synergize each other. Kipi, you had a thought. I didn't want to miss hearing what you're getting excited about for health equity.
Yeah, I mean, I've been increasingly getting excited about these issues of data. So, our organization is in the patient engagement space and focused on communities of color, vulnerable populations. So our customers are health systems and or payers and some community orgs. But as we've gotten deeper in the work, what's become clear is, and COVID really just put a pin in this, is that we don't have consistent data available on these different equity barriers at scale across our country. So while we have all the studies and research, peer-reviewed, done to the highest bar of research that show racial disparities and other disparities that have been around forever, so we all know they're there. When you start to think about moving the needle, you can't sustainably change what you can't measure. So if I can't measure what the change is around any state, whether it's population health-wise or clinical, by those various factors over time at that level of depth, I can't really do anything. So, recently, and actually just today, I don't know if you guys saw this, but it was in Health Affairs. So the Robert Wood Johnson Foundation just launched the Independent National Commission on Public Health Data Systems. That got me very excited, because that's going on at the national level, really starting to think seriously about how we put in place the public health data infrastructure, along with the equity dimensions that matter over time, so that we can create transparency. And then I'm involved in some of those efforts in our state here in Colorado. And so I think there's a real move to start to think about measurement. And because otherwise everyone's hiding. If we can't measure it, people can hide behind how they feel, right? And whatever political positioning anyone wants to take. Whereas when the data's there, then it's just about the data. So to me, that's foundational to shift the industry. So even to Anoop's point, no one yet, I would love to see Rock Health or Startup Health create a total addressable market, or a TAM, around different health equity dimensions. I see my friend Chelsea smiling. We had this conversation not too long ago, but there is also a business case to health equity. It's not charity. Like, if Black and brown people are more sick and payers are bleeding money and they're making decisions based on money, it's clear that it's in their economic interest to solve the problem. But I haven't seen anyone say, what's the total addressable market through a racial disparities lens for solving the issue for diabetes for Black and brown people in the country? What's that number? It's billions of dollars, by the way. But no one's done that. So I think we need to see some leadership in those spaces too.
I saw a great figure a day or two ago that just looked at asthma. And Chelsea, you might be able to help me out with this number, but I think it was over 1 billion that could be saved if we just address asthma in Black populations in the workforce alone. So I mean, I think there is immeasurable ground because we don't have the data. We're not using it to drive forward. To really think through how we might best take care of communities and take care of individuals and people, and really drive towards health equity. I think a lot of us might find ourselves in a state where we might have Latin feet and be in paralysis of not knowing what's the next step to take. I think today we really started to see how we can open up our minds and towards action and really energize across our silos and across our different domains to move and row together in this same boat towards health equity. I'd love, as we're coming to the end of our day, to get a few final thoughts from our panelists. Anoop, why don't you lead us off?
Yeah, I mean, KP, that was again, just a great point. I think, again, the idea of there's just, in addressing equity, there's just so much, like you can make a great value-based care argument for why it just makes sense, not both just because it's from a payer's perspective, and then again from an ethical, just that let's do what's right. And I'm just so glad that equity is now a term that is just part of the almost the DNA now of more organizations, and just the vernacular, and everyone sort of is talking about it, right? And so I think that's one big, huge first step. I know that lots of organizations now have like DE&I sort of like programs. For us, we're really trying to bake that into our DNA as an organization, and think about ways that we can address equity. And COVID has really brought to bear just how much equity matters in terms of the way that we deliver care, both from who we're serving and trying to get our folks vaccinated, and how much of a struggle that's been, right, in the last several months for us. And also from our staffing perspective, and this has been across the healthcare industry, right, where you see not just racial inequity, though that's very much present, but also just from a socioeconomic status. When you look at organizations, the docs are the most vaccinated folks, and then nurses, and then your MA staff, and that's the case in nursing homes and hospitals, and in our organization as well. And thinking through ways that we can impact that through technology and just through building trust has really been driven home the last several months.
Tracy and KP, a few final thoughts.
Yeah, I mean, KP, the previous comment, so powerful, right? And I'm completely there with you, right? We can't address anything until we know how to measure and how we can derive insights. I will also say, as sort of a call to action, or, a little bit more of an actionable thing for people, is that we should all be asking whose voice is missing from the table, right? And to actively be seeking that out when people are not there, right? Because I think we all come in, from places of varying privilege, right, in our roles. And so as much as we're able to exercise that privilege to bring the right people to the table and to uncover the pieces that are not, the voices that are not currently being heard, I think it's our responsibility to elevate those. And I will say, even with the data, we need to really clearly have people all along the pipeline, including in the decision-making roles, we need to have diverse folks there, because from a much broader perspective, the latest CNN report, the CBS report, Dr. Joy Buolamwini from the Algorithmic Justice League, basically that entire series was based on her book. They interviewed her extensively, and she was essentially erased from any of the credits there. And I think that, it really shows how far we have to go to not only build on the work that folks are doing, but to also recognize it and to elevate them so that we can continue to make sure that this flourishes. So I will just say, from a broad perspective of, data and technology, we need to make sure that that particularly translates into health, where we know that the data are not perfect. So there are great opportunities there.
KP, final thought?
I love that. And I think that's so important, particularly about who's in the room. And I would say that when people get in the room, we also can acknowledge that they're a minority in the room. And it can sometimes be very hard to feel like you can speak your mind, because there may even be, in some cases, a certain amount of tokenism that people feel, or who's actually in that room, they're the only voice. But I would say, building on Tracy's theme, which is we have to be vocal. So every room I'm in, I've decided, I'm going to be vocal. I'm not going to be quiet. And I think that that's the other part of this. So I really love that we need to think about who's in the room, and we need to support our colleagues that are in the room in being vocal, because it's very hard. So let's not forget that it's very hard to also be vocal when you're that minority in the room. But I think that, the other theme I just like to note is that while COVID has brought this issue of racial disparities, racism in health care, health equity to the forefront of the national conversation, I think what's going to be telling is what happens next. I do feel like there's signaling, not just from the federal government and from local government, but also from community organizations and activists, that we're not going to let it go. So this feels like a different moment to me. This doesn't feel like a moment where we're talking about health equity this year and then it's gone. I think something's different. So my hope is that we move into a much broader conversation beyond COVID, and that we empower our partners and community orgs to be able to facilitate that change.
Well, I want to thank all of you, KP, Tracy, and Anoop, for being in the room and also for being a part of the table, and really leading on health equity and digital health and venture, as well as care delivery. I think at Health Design, this is the stuff for us, being in this conversation and moving towards action with a diverse group of stakeholders, people who come from different domains, and breaking those silos. One of the reasons to sit within a healthcare system is to move beyond a healthcare system, to truly meaningfully impact the lives of patients. So, as we continue to work together as an ecosystem and really drive towards health equity, I look forward to that future. I really look forward to this group of people as it expands and the momentum builds, beginning to tackle some of these very deep-seated issues around health equity that we're faced with as individuals and in our communities at large. I'd also just love to go ahead and thank our really fantastic crew who support us throughout the day, our production staff, as well as the health design crew who've been making everything flow seamlessly behind the scenes. And again, a call out to our sponsors, Alam and Harry and the team, as well as Avestria, InOn, our healthcare data analytics group, Coach Me, and Make Just Right. We've really enjoyed what has been an action-packed 2 hours, and hope that the conversation won't stop here. Certainly keep tweeting out and keep the conversation going with Equitable Tech-Enabled Care, and join the LinkedIn group as well. We look forward to staying in conversation, and you can find us active and live with mural boards and continuing to think and face health equity and chart the path forward on our website, emoryhealthdesign.com. So thank you everyone so much for your time and your energy today, and looking forward to continuing connecting.
Thanks so much, Monique and team.
So great to meet everyone. Have a good one.
Thanks so much, Monique. Thanks, everybody.